Major bleeding, the unusual suspects. A case of intracranial and intra-abdominal hemorrhage in a patient with refractory mantle cell lymphoma treated with cenobrutinib. Hello everyone, my name is Dr. Jarinja Kulukra. I'm a PGY2 at University of South Florida. The leading cause of death in United States is attributed to heart disease, followed by cancer, COVID, accidents, and strokes, according to the data from CDC in 2020. A subset of all these deaths is attributed to major bleeding, which has been steadily increasing with elderly population, increasing oral anticoagulant use, and other comorbidities. This case describes a second-generation BTKI, Bruton tyrosine kinase inhibitors, as a probable cause of intracranial and intra-abdominal bleeding. A 72-year-old man presented to the urgent care with worsening fatigue for the past 2 weeks. He has a significant past medical history of thyroid cancer and had undergone thyroidectomy, diabetes mellitus, hypertension, CKD stage 3A, DVT, and pulmonary embolism on apixaban. He had undergone multiple treatment regimens for his stage 4A mantle cell lymphoma and was currently being treated with cenobrutinib while awaiting CAR T therapy. The physical examination revealed basilar crackles and fetal edema bilaterally. CBC and CMP were significant for pancytopenia and elevated creatinine but unchanged from baseline. Imaging was remarkable for patchy ground glass and airspace opacities bilaterally, particularly in the left upper lobe. On admission, apixaban was discontinued due to thrombocytopenia and was initiated on levofloxacin for community-acquired pneumonia with improvement in symptoms. On day 7 of admission, patient developed left upper extremity weakness and aphasia. CT head was done and showed acute on chronic 2.5 cm right-sided hemispheric subdural hematoma extending to the inferior aspect of the right frontal lobe, resulting in 0.4 cm right to left midline shift and acute blood products along the fats and tentorial leaflets. It was initially attributed to thrombocytopenia with platelets at 47,000. Transfusion protocol target was changed to 100,000 and patient was initiated on levetiracetam. Neurosurgery was consulted and performed a right frontal and parietal craniotomy with evacuation of the hematoma the following day. Patient developed hypertension on postoperative day 2, requiring pressor support, and CT abdomen was done showing hyperdense material within the peritoneal cavity consistent with hemoperitoneum, and most hyperdense adjust to the spleen, considering splenic laceration. The patient had a platelet of 109,000 at the time, and the apixaban had been discontinued for more than 48 hours. Considering this, cenobrutinib was thought to be the causative agent or a contributing factor to the major bleeds. Due to the poor prognosis, family proceeded with comfort measures. Cenobrutinib is a second-generation BTKI approved for mantle cell lymphoma and marginal zone lymphoma, as well as for Waldenström macroglobulinemia. It acts by inhibiting BTK, which is an integral part in signal transduction of B-cell antigen receptor in malignant B lymphocytes. It also acts on the thrombus stability as well as platelet activation, as BTK is a downstream molecule of the platelet transmembrane receptor. In vitro studies demonstrated inhibition of collagen-induced platelet aggregation and von Willebrand factor-induced platelet aggregation. It has action both on the platelet quantity as well as quality. Grade 3 or higher hemorrhage, including intracranial, GI hemorrhage, hematuria, and hemothorax, were reported in 3.4% of patients using cenobrutinib. In conclusion, this case demonstrates the need for looking at alternate causes as well as contributing factors for major bleeding. Cenobrutinib and other BTKI are known to increase the risk of bleeding and need to be discontinued in any grade of intracranial hemorrhage. Withholding cenobrutinib for 2 to 7 days pre and post surgery is recommended. Thank you everyone for listening to this case. Thank you.